here. You might not be able, thank you. You might not be able to unmute yourself, but there will be time for questions and answers, and you will be encouraged to place your questions in the chat. And we hope that you will do so. Needs assessments of people with PD reveal that sexual health is sorely under-addressed by PD healthcare providers. In addition, many healthcare providers do not feel comfortable starting a conversation about sexual health and do not know what help to offer. Hopefully, through this course, we will give you some tools to do both these things. This course is a collaboration between Stonybrook Medicine, New York Institute of Technology, the Friedberg JCC, and American Parkinson's Disease Association. I would like to introduce representatives from these organizations who will be helping to introduce our speakers and moderate the course. Erin Harrabees is the Neuroscience Navigator at the Stonybrook Parkinson's and Movement Disorder Center at Stonybrook Medicine. Caitlin Pavlikoich is the Parkinson's Coordinator at NYIT and the Coordinator of the APDA Information and Referral Center at NYIT. Welcome, Erin and Caitlin. Now let's get started with our first speaker, Dr. Joseph Alukal. Dr. Joseph Alukal is the Andrew Sabin Family Foundation Associate Professor in the Department of Urology and Director of Men's Health at Columbia New York Presbyterian. Dr. Alukal serves in a number of roles at a national and international level for professional specialty and subspecialty organizations, including the American Urological Association, the American Society for Reproductive Medicine, and the Society for the Study of Male Reproduction, of which he is a past president and current board member. He maintains a busy clinical practice in men's health, male infertility, male sexual dysfunction, and general urology. Thank you so much, Dr. Alukal, for being here today and sharing this valuable information. I'm thrilled to hand the mic over to you. And let me see, 1 second. You should be all set to unmute and get started and share your slides.
Great, that did work. Thank you.
My pleasure.
It was trying to tell me something. Thanks so much for the invitation. I'm really pleased to be able to help out with this program and talk about a topic that I think is really important, and that's sexual health in the setting of Parkinson's disease. And I'm just going to put my slides up. I believe this will work when I do this. Can everyone see that slide?
Yes, we can. Thank you.
Great. All right. So just to get started, I don't have any disclosures that are going to be relevant to today's talk. Nothing we need to worry about. I'm on an FDA committee that does talk about urologic drugs a fair bit and reproductive medicine, but we won't be discussing anything relevant to that today, nor will we be discussing any off-label treatments. When you think about how does Parkinson's disease intersect with the urologist's office, and certainly I've had partners over the years who are super busy in this space and have taken care of lots of patients with Parkinson's, almost always the issue that the patient's bringing to our office has to do with urinary complaints. Doctor, I'm peeing much more often than I used to. I'm peeing more often at night. It's not as controlled as it used to be. And I'm occasionally having accidents. And all of those things are valid reasons for a Parkinson's patient to get seen in a urology office. But as well, you know, because my partners were thorough, they would ask their patients all the time whether or not they had sexual health complaints. And if they did, most commonly that complaint was going to be ED or erectile dysfunction. They'd send those patients along to me. And so I've been in practice in New York City for 15 years. 10 of those years I was at NYU. These past 5 years I've been at Columbia. And especially at NYU, I used to ask myself all the time, I wonder why this isn't something anybody talks about. You know, it's just not sort of commonly discussed in the literature. And it turns out that there really wasn't a lot written about this. And in the past few years, maybe the past 5+ years, there's a fair bit more in the way of publications trying to get a sense of how many patients with Parkinson's disease would tell you, hey, I've got a sexual health complaint of some sort. And those complaints can include, in addition to ED in the male patients, anorgasmia in patients, either male or female, and ejaculation in male patients. And then I didn't write it down here, but lastly, a change in libido, a lack of interest in sex. And in lots of these different sort of small series where people are asking this question, it looks like it's about half of patients who would say yes. And then in a larger study called the PRISM study, they found that it was about 50% of patients, male or female, with a slight predisposition in the male patients saying yes, who endorsed any of these sexual health complaints. And it was 70% of patients in that study who, of the male patients, that is, who reported that they had erectile dysfunction. So it's not at all an uncommon problem. And again, begs the question, well, why aren't we talking about it more? And I may not be able to answer that for you. And I'm sure a lot of the people on this call understand better than me what the barriers might be to getting sexual health as an issue out there in the Parkinson's community. But I would remind people, look, there's some tried and true strategies that we have for managing these sexual health complaints. And when we go through them, we can keep in mind Parkinson's disease and talk about how it specifically tailors to what we can or can't realistically offer to patients. But these should be treatable problems. We ought to be able to figure out ways to treat these problems for our patients. I am going to focus on male sexual health complaints because that's what I do in my practice. Is certainly my emails at the end of this talk. If you have questions from a female perspective, I can attempt to answer them myself, or I can push you along to one of a number of partners or colleagues I have around the city who focus on female sexual dysfunction. So to walk it back also to kind of the basic level, part of the problem, I think, has to do with the fact that erectile dysfunction is a common problem. So Parkinson's tends to be a disease of either middle-aged or elderly patients. It's not something that's happening that often in the young adult. And there's a tremendous overlap, for example, with erectile dysfunction in the same age range. So it's a problem in multiple large population-based studies. It's affecting about 40% of 40-year-olds, all 40-year-olds, and that number goes up to about 70% of all 70-year-olds. And again, it's a common reason for a patient to put themselves in front of a urologist. 1 out of every 5 visits to a urologist is for this particular reason. When I'm seeing somebody who has these issues, I'm trying to divide them up amongst a number of different potential causes. Do they have poor blood flow to the penis as a reason for their problem? Is that something I should be investigating for some reason? Might it be telling the patient something about their overall health? Do they have a neurogenic cause, either a nerve injury of some sort or a neurologic disorder, which is what we're talking about here today? Could there be a hormonal issue of some sort? We'll come back to that one as well. And then lastly, the psychogenic component, which I do often have to remind people isn't just me telling somebody that they have an emotional issue that's contributing to their sexual dysfunction. It actually has to do with their emotional state causing physical events in their body that make it very unlikely for them to be able to get or keep an erection. And very often, once patients have some other of these physical causes resulting in erection problems, they're going to then have this psychogenic component or this emotional component come along for the ride. They start asking themselves questions like, is this going to work in terms of their ability to actually perform sex? And once they're asking that and it creates some anxiety within their body, it's not going to work. It's kind of a self-fulfilling prophecy. Not always that easy to treat. I have one treatment option that sort of end runs this whole issue, but otherwise I have to get people to understand this and to give them something that can enable them to stop worrying about their problem quite so much. I can't just tell people not to worry about it, though. I recognize that's an absurd request. People worry about these kinds of issues for a reason. Their sex life is important to them. Instead, what I'm hopeful of is that once they believe in whatever treatment it is that I'm offering them, they will be less worried about this problem. That in turn is a virtuous cycle, and things will start to get better to some extent. What am I doing to evaluate these patients? Everybody should be getting a history, a thorough history, and that's usually when the patient will disclose to me, I've had a diagnosis of Parkinson's made, for example. That history should include their prior medical history, the medications they take, and any surgeries they've had before, a family history, and a physical examination. And that includes, in our case, an examination of the genitals. Nobody is excited to see the urologist for obvious reasons. But it's an important part of figuring out who has physical causes for these sorts of problems that they need to know about. A laboratory evaluation is going to include hormones. And so I'm checking with blood drawn in the morning, a testosterone level, some other hormones that come from the brain that have to do with the brain's assessment of how well the patient's testicles are doing their job, as crazy as that sounds. The two jobs of the testes are to make testosterone and to make sperm, and those two processes are related to each other. And they're important enough in terms of reproductive health and fitness that your brain is paying attention to those every moment of every day. And so if those processes have gone offline for some reason, your brain should start to make more of certain hormones in order to compensate for that. And sometimes I get a clue to that sort of a process going on by checking these other hormones. Sometimes people need imaging, something called a penile Doppler ultrasound, which is just really an ultrasound of the blood flow, the arteries within the penis. We take those images before and after the patient's been administered a tiny injection of medicine that should result in an erection. If the patient doesn't get an erection, the ultrasound is there to tell us why. Usually, I don't always do that ultrasound in everybody, but it can be useful in certain patients. Usually at the end of that, I have a pretty good sense as to what is really the predominant driving force in this patient's erection problems, and then what might we do about it that has the best chance of working or making a meaningful impact. What are our treatment options? So we have the famous pills. We're going to talk about them a little bit. Viagra, Cialis. There's two other drugs in that family. There's a treatment that you could put into the head of the penis, the hole where the patient urinates out of, what's called the urethral meatus, which works differently than the pills do. So in somebody where the pills don't work, there's a chance that this stuff works. Similarly, injections of a medication very similar to that suppository I just mentioned, that injection goes into the base of the penis along the side, with a tiny needle. A mechanical option, which is a vacuum erection device, basically suctions blood into the penis. Surgical options, which we'll talk about for 2 seconds, what's known as penile implant surgery, and then hormonal treatments, which we'll talk about. Obviously, when you're dealing with patients who have Parkinson's disease, you have to make a slight modification in terms of what it is you're more or less willing to use on this list. If the patient, for example, is single, it may be difficult to expect him to learn how to inject himself if he has limited or lessened use of his hands. It's a difficult thing for lots of patients to figure out how to master, although many patients will tell you once they've learned how to do it, it became very, very easy for them to do it. But it's not easy for somebody who doesn't have great manual dexterity. And there's lots of different conditions where patients end up in this situation. Similarly, patients with penile implants, they have difficulty using those if they don't have great use of their hands. So we have to keep that in mind when we're making suggestions about what might best work for one of our patients if they have a Parkinson's diagnosis. The causes that we're talking about, that I mentioned before, let's look at neurologic causes at first. So certainly the most common things that we're going to see in a urology practice, prior surgery in the pelvis, either removal of the prostate for cancer, removal of the bladder for cancer, causes injury to the nerves that live in the pelvis and tell the penis it's time to get an erection, okay? Diabetes injures nerves throughout the body, and in the same way, it can injure these same nerves. Any neurological disorder can potentially cause erectile dysfunction for neurogenic causes. And what you have to keep in mind is the pills as a treatment option work as an amplifier to the signal that's telling the penis to get an erection. So if those nerves have been injured for whatever reason, that signal is not making it to the penis. And so you have to be willing to accept the possibility that the pills are less likely to work. When I'm speaking to patients with Parkinson's disease about Viagra or Cialis for erectile dysfunction, I counsel them, look, this may not help as much as we needed to, but you're going to try this for a while, come back in and let me know how well it worked for you, and we'll make a determination, are we close enough to an effective result that maybe I can increase the dose a little bit? Relatedly, how well are you tolerating the medication? Somebody where that nervous system function is completely gone, and we have to figure out a way to bypass that. And that, generally speaking, means that we're talking about those local treatments administered to the penis, because those drugs are analogs for the signal that tells the penis it's time to get an erection. Vascular. And so what happens in the penis? First, that nervous system signal tells it, okay, it's time for an erection. And what results inside the erection spaces of the penis is the relaxation of smooth muscle cells inside there. As a result of that, there should be an increase in inflow of blood. But if the blood vessels leading to that space aren't healthy, and that can happen for any number of reasons, the same sort of reasons that somebody is at a higher risk of having a heart attack, for example, again, diabetes, which can certainly be a double whammy for this process, the patient who continues to smoke, any of those sorts of scenarios, and now we have to worry about the possibility that even though that signal is there doing what it's supposed to do, there's not adequate blood flow to result in an erection. Relatedly, we did actually study this in lots of different groups of patients, trying to determine, hey, what do we understand about the guy who's developed erectile dysfunction? He's coming to see a doctor like me for the first time. Do we know anything about his future risk of other diseases? And in a very, very good study of thousands of men being looked at for a different question, half of them received a drug in an effort to try and prevent them from developing prostate cancer. The guys who received the placebo in that study, this particular urologist studied them for more than 10 years. And what he observed was that there was a meaningful increase in their likelihood of a future heart attack or stroke if during the 10 years of the study, they came in and reported to the doctors observing them, hey, I didn't used to have problems with erections, but now I do. And so in the subsequent 20 years, there have been lots of other studies that have confirmed this finding, help us to believe that this is a really good predictor of somebody's future cardiac risk. And we do use this to modify patient behaviors. I use this fact to convince people to quit smoking all the time, or at least I hope I do. I send a lot of patients along to the cardiologist who I work with. And so I bring that up because part of what I think goes on in the Parkinsonian patient is, as they're aging and people are more and more worried about their Parkinson's, it's important for us not to forget about the other disease processes that are important to them as well. And so I have had patients with me long enough to tell me things like, you used to give me Viagra and it worked and it doesn't work anymore. And I have to remember to involve their cardiologist and make sure that nothing has proceeded in terms of their sort of potential for having a heart attack in the future. Hormonal issues happen to all of our patients. And so, it's certainly more likely, again, in the diabetic patient, again, in the obese patient, in somebody who doesn't have great function of the testicles. Maybe he lost a testicle for some surgical reason years ago. But in those patients where not enough testosterone is being produced, it's very likely that that patient might tell you, I've lost my interest in sex, doctor, as well. When I do actually try and fool around, I can't get or keep an erection, even whether or not I've taken medication. Fixing their hormonal deficiency can sometimes correct those things, but absolutely hormonal deficiencies have other impacts on the patient's overall health. And it's important to keep in mind that as we take care of Parkinsonian patients as they're aging, we have to think about the idea that hormonal replacement in those patients in whom it's appropriate can help with things like bone density or muscle mass, which in turn can help forestall problems that the patient might have that could really be medically serious. Something like the patient losing his balance, falling, breaking a hip. That's a serious health event. And so actually identifying those people who have hormonal deficiencies and correcting them might help to offset that kind of risk and is again important to the patient's overall health. So going back to what I was talking about in terms of the pills and who are we going to use them in, I would say that, other than the fact that there is a population of patients with Parkinson's who are going to be resistant to these medicines, again, because of neurologic reasons, I would say this is the most reasonable place to start, okay? The things that you want to make sure patients understand are, how do you take these medications? Lots of people over the years who, have tried one or another of these drugs, not had it work, and it was only because they weren't taking it correctly. The medication has to be taken, Viagra, Cialis, Levitra, or Stendra is the fourth one. Any of those have to be taken on an empty stomach, and you have to give them something like a half hour to an hour to kick in. If you take them right after having had dinner and you attempt sexual activity 2 minutes later, it's not going to work. The medication's not going to help because it won't yet have been absorbed into your system. Once that absorption period has been moved through, depending upon the drug, there's a window of time that the drug is in your body and could potentially have an amplifying effect to you getting an erection, such that if you do something sexually stimulating, it's more likely that you'll get a better erection, you'll get an erection more easily, or that erection is more likely to last. Patients misunderstand this all the time. People who tell me, doctor, that stuff didn't work. And I ask them, well, what did you do? Well, I took it and I turned on the Yankees game. Well, unless it was the most exciting baseball game you were ever going to watch, it wasn't going to help in terms of the medication, that is, in terms of you being able to get an erection. So actually doing something sexually stimulating is an important part of this. And it relates to this last bullet point here. It is always surprising me. It's probably 1 out of 3 people who would tell you within a year, you know, somebody gave me a prescription for this stuff, doctor, but I stopped taking it. It just wasn't working well enough. The other reason is that, you know, some people have side effects with it. Headache, upset stomach, and sometimes backache being the most common reasons that a patient might discontinue one of these drugs. Of all the drugs in that family, the one that I think works best for people for a few reasons, if it's not specifically causing side effects, is Cialis. That drug stays in your system longer than the other 3. And if people start taking a low dose of it every day, that really eventually it ends up that amplifier effect is on in their body all the time. I think that helps people in that they don't have to worry about planning as a result. I think it also helps people in terms of seeing the benefit of more frequent erections when they're not attempting sex with a partner. And so they're less anxious. And as a result, they actually see a greater beneficial effect. And that carries over into minimizing their anxiety when they are actually with a partner. Okay. Relatedly, though, when we're talking about Parkinson's patients, another one of the issues is, again, urinary complaints. And that one drug, Cialis, taken every day, is the only one of these drugs that actually has an FDA-approved indication to treat urinary complaints related to prostate enlargement in a man. And so you might find, and I found in patients with Parkinson's, that this could be a very good drug for both those problems. It can help with some of the urinary complaints that patients have. It can help with erectile dysfunction. And it's very well tolerated from a side effect profile. It's very easy to take. So remember that as a good option, everyday Cialis. Certainly if you have questions about how do I obtain this drug, et cetera, I can help with information in terms of insurance coverage and things like that. Couple of these I mentioned already, you know, the intraurethral option. This tends to be very difficult for people to obtain for cost reasons. It's not readily available in most pharmacies, and it's not well covered by insurances. The same sort of medication is available as an injectable. 2 options that are, you know, like FDA approved brand name drugs, also difficult to find and also expensive. And then some variable options that are typically made by compounding pharmacies. And those drugs, they really do work for people who have loss of nerve function in terms of the nervous system signal telling the penis to get an erection. These medicines work in spite of that. But again, my concern with this in somebody with Parkinsonism is that they may have a difficult time administering it to their penis. Certainly it is possible if the patient tells you, well, I have a partner who I've known for forever. We're in a very committed relationship. I have no embarrassment about asking that person to do this for me, and they're perfectly comfortable with it. Then I would say that would be a reasonable approach and has every reason, you should have every reason to believe that this would work for that patient. This is the kind of thing where I would say, you know, you probably do want to involve a urologist like myself. Prescribing, you know, one of these pills, especially daily Cialis, you don't necessarily have to have involved, you know, someone like myself. You could probably figure that out on your own. What are the options when this were to fail? You know, that vacuum device that I alluded to is really just a mechanical device. It looks like a tennis ball cannon. It fits on the penis. And then remarkably, you either use a hand pump or an electronic pump that suctions blood into the penis. This does require some manual dexterity. There are no medical contraindications to using this, however, so people could try this at any point. I remind people that a dedicated sexual health therapist can really help, especially when they're trying to deal with maintaining a sex life in spite of a chronic illness. And then again, hormonal therapy, as I alluded to, may be beneficial to more than just a select few patients with this condition. Let's talk about the surgery option for just 1 second. So penile implant surgery has been around in the US now for almost 50 years, more than 50 years, sorry. And the first device described was made by a urologist in Texas. And at first, I mean, it really was troublesome, these devices. You know, the mechanical malfunction rates were really, really significant, almost 1 out of every 2 per year, and an infection rate of 1 out of 4 per year. And we've really done wonders over the years. The infection rate is down to about 1% in our very large series for a lot of reasons. We're basically coating these devices in antibiotics. And the failure rate's about 5% per year, which is a really acceptable number. The average lifespan is therefore about 10 years. But sometimes there's some patient satisfaction complaints. People, especially single patients, will complain about things like the ease of use or the size of the device, sort of comparing themselves and their current device and penis to what they recall when they were younger and healthier. But importantly, these are reasonable options to think about Parkinson's patients with one caveat. So the device comes in 3 varieties, 2 of which are basically inflatable. They're a series of balloons and tubes filled with salt water, and the patient works a pump in the scrotum that results in the water going into the balloons and resulting in an erection. Okay, there's 2 balloons inserted in the penis that look like blimps, and when they're filled up, the patient has an erection. This also requires some reasonable manual dexterity. Again, it's a totally appropriate option if the patient tells you, I'm in a stable situation with a partner who'd be willing to work this for me. If they don't have great use of their hands and they're alone, this is not a good idea. The oldest version of this device is a bendable or inflatable device. It has a metallic rod running through the middle of it that has some rigidity to it, but is also still bendable. And so this is probably the least difficult surgery for the patient to recover from, and is certainly the most easy for somebody to use, even if they did have a limited use of their hands. So this would be an appropriate option to keep on the table for all patients with Parkinson's with erectile dysfunction who wanted a surgical option. There's 2 companies in the United States that make these devices, and most of us who do this surgery are familiar with and use both of these companies. Okay, so on the one hand, you know, when I talk about people being satisfied with this, it is still a majority of patients who would say that they're happy with the decision to have gone through this, anywhere from probably something like 7 out of 10 to 5 out of 6 saying, yeah, I'd do it again, or I'd recommend it to a friend. But I still think we have a long ways to go in terms of, you know, lowering the risk of complication even further. You know, that includes getting the infection risk down to as close to 0 as possible, and making patients more happy with this. You know, I'd be thrilled to see this number at 95% instead of 70%. Hormone treatment. So one of the things about this, it's super controversial for lots of reasons. And again, we're talking about a group of aging patients. Questions like, is putting my partner on testosterone going to cause him to have a heart attack? Is it going to cause him to have prostate cancer? Is it safe if he's been treated for prostate cancer before? And this is just one of numerous studies that we've, you know, participated in, reviewed, trying to establish that for most patients, testosterone replacement is safe. And so this was a specific example where we demonstrated, and it was controversial at the time, about 9 years ago, that in patients with lower intermediate risk prostate cancer, you can give them testosterone safely and follow them for any number of years without any issue. And so just this past year, a New England Journal study that looked at thousands of men with a history of heart attack or stroke who had a low testosterone, half of them were placed on testosterone, and within 2 years, there was a negligible number in either group who had had another heart attack or stroke. That study is ongoing with continued follow-up all the way out to 10 years, and we hope to see the same thing at each of the time points that they're going to analyze that data. So I just feel like there are more reasons than people realize for us to say to patients, it's okay to put you on testosterone, it's going to be safe. In patients with Parkinson's disease, there's obviously this benefit in terms of motor function, potentially strength, balance, and then bone density. So lots of reasons to think about it in this group of patients, and I think a worthwhile topic of study. But I look, there's literally no one who's addressed this in the literature yet. I think it's probably ripe for some sort of analysis. Okay, so one last detail. This is a photo of a place where I jumped out of a plane with my mother-in-law and my brother-in-law about 12 years ago. I was very thankful that day for my functioning parachute. Obviously, I've managed to destroy all the photographic evidence of our actual faces that day. I screamed the whole way down. My mother-in-law had a great time. This is a study that was published in the British Medical Journal in 2003, talking about the fact that there are no randomized controlled trials about the negative impact of skydiving without a parachute. And the point is, we don't always have perfect studies or perfect data that can drive us in terms of saying, well, this is what we should do for all of our patients. At the same time, we can use our common sense standards. And I think this is an area that is, relatively speaking, new. Those of us who are asking questions about sexual health in patients with Parkinson's disease. And relatedly, I think even though we don't have data, if we use that common sense standard, we know which treatments are the right treatments to offer these patients and how it might help. Feel free to think about some of those treatments on your own. Again, something like a daily dose of Cialis is a reasonable place to start. But also, you don't have to be afraid to involve a doctor like myself. You know, if you have questions or if the patient has questions, please feel free to send them along to me. I'm happy to help. And so here's my information, office number, and email in case you need it. And I'll open the floor to questions. Thank you.
Dr. Alukal, thank you so much. That was an excellent presentation and very informative. And we do open the floor up to questions. If you can kindly type them into the chat. And Erin, I invite you to moderate the Q&A.
Hi, so we do have one question that says, do certain medications lead to or affect erectile dysfunction?
Sure. There's a long list of medicines that are going to potentially predispose the patient to problems with erectile dysfunction. Most notably, drugs that help to control blood pressure. This is bad news because patients come to me hoping that I'm going to tell them you can stop your blood pressure medication, and I've never said that to anybody. Obviously, what we use blood pressure medications for to try and prevent the consequences of uncontrolled high blood pressure, which include things like stroke. I have to work around that when I'm treating people if they're taking medications for blood pressure that might predispose them to that. In terms of Parkinson's, dopaminergic medications shouldn't be predisposing patients to sexual dysfunction in terms of erection issues. I tend to think of it as being more a function of the disease state than it is the treatments.
Are there any other natural options to assist with erectile dysfunction, such as food, tight clothing?
Clothing, I can't think of anything. Food, I always tell people, look, you know, people have been looking for those sorts of answers since the beginning of time. There are some natural compounds around the world that have been studied and do appear to have some effect in terms of treating erectile dysfunction. A good example is yohimbe, which comes from the bark of a tree in Japan. Okay. That's been studied to the extent that you can get that as an FDA-approved treatment, like as a prescription strength drug. But you know, that stuff has to be taken basically around the clock, and it tends to cause people a side effect. They'll tell you that their face is red like a stoplight when they're taking it. So many times they're like, I may as well just go back to taking one of the medicines. And I go, I hate to say I told you so, but that's what I'm more familiar with and more comfortable with using, and I think it to be safe. That being said, I would say that probably one of the best natural strategies for improving sexual function is weight loss. You know, if for whatever reason you could say to me, okay, I can figure out a way to, with the help of some sort of a trainer or somebody else, I know that's even more difficult in the setting of Parkinson's, to lose some weight through either diet or exercise or both. I'm willing to bet that patient that if they did that over 3 or 4 months, that in those 3 or 4 months, they'd be telling me, you know, my sexual function improved.
Okay. And then what about medications for depression? How does that affect?
Antidepressants are also, they tend to do a number on libido. People will sometimes tell you, you know, doctor, this got my mood better, but it made me even less interested in sex. Sometimes as well, people will specifically complain of anorgasmia with those medications. You know, doctor, I can't engage in sex, but I can't get to the finish line. And so all of those things, of course, can, as an associated problem, cause erectile dysfunction. Same sort of thing. Somebody who comes to me taking antidepressants, I'm never going to tell them, hey, let's stop these and see if your sexual function gets better. You know, that's a discussion they have to have with their psychiatrist or their psychopharmacologist in terms of, you know, what are different medication regimens we could try that are less likely to cause me these side effects.
Okay. And then are the vacuum pumps available commercially, or does health insurance cover them?
They are now only available commercially. And so that had to do with the fact that a few years ago, they used to be covered by insurance and they were medical grade with warranty, all this stuff. And Medicare, it became obvious to them that there was some meaningful degree of Medicare fraud going on relating to these things, which I found remarkable at the time. Once Medicare stopped covering them, then the commercial insurers stopped covering them, and now they're only available. You purchase it like you'd purchase any other sort of item online. And relatedly, I've had patients in the past few years tell me, you know, I feel like the quality of these things is less. You know, they're more likely to break, difficult to get anybody to ever fix it if it's broken. I feel like I put a few $100s, you know, sort of flush it down the toilet, and I go, I'm sorry. It's not a first line recommendation that I make to people.
Okay. Then to kind of tack on to that question, should patients use these under physician supervision?
People can figure out how to use them on their own. We used to, when it was insurance covered and we had more people using them, a representative from the company used to come around with some sort of silicone model, and they would demonstrate how the thing was actually correctly used, which I also thought helped with people being more likely to learn how to use the thing correctly, use it correctly, and then continue to use it with time. None of that service is sort of available anymore. I wouldn't be surprised if you can find some sort of meaningful educational material on it, say on YouTube, but I offer that with a warning also. Gosh, only know, you know, what else are you going to find when you try that search? So maybe I'll withdraw that suggestion. But, you know, yes, if you're going to ask about trying to use one of those things seriously, find a urologist like myself and ask us first.
Okay. All right. Thank you so much. That seems to be all with our questions.
Okay. Thanks, everyone.
All right. Thank you so much for joining us.
Happy to help. I'm going to stop my share. Great.
That's perfect. All right. Thank you so much. In the next section of this course, our two presenters are Dr. Rebecca Gilbert and Gloria LeBeau. Dr. Rebecca Gilbert is the Chief Mission Officer at American Parkinson's Disease Association, APDA. She plays a key role in developing APDA's long-term mission strategy, oversees APDA's research portfolio, and provides medical and clinical expertise to support APDA programming and educational content. She is also a movement disorders neurologist and maintains a practice 1 day a week in New York City. Gloria LeBeau is a licensed clinical social worker, is the Director of Social Work Services at the Friedberg JCC, and a trained psychotherapist providing consultation and individual and group counseling to adults and their families in her private practice. She is also an adjunct professor at the Adelphi University School of Social Work. Gloria has special expertise facilitating support groups and gives presentations on areas related to aging, bereavement, caregiving, and Parkinson's disease. Rebecca will talk to us about APDA's ParkinSex, a resource that can help people with PD navigate the conversation of intimacy with their partner. Gloria will talk to us about sexuality challenges in the couple relationship. Rebecca, the mic is yours.
Thank you so much, Sarah. And thank you so much, Dr. Alukal. I'm going to share my screen. And you'll let me know if you can see it. All right, you can see my screen, hopefully. And
yes, we can.
Okay, great. So I'm going to be talking to you today about a resource that American Parkinson's Disease Association has developed in collaboration with Havas Health, and it is called ParkinSex. So the challenge that we were trying to address is a challenge that Dr. Alukal talked about, which is sexual dysfunction in Parkinson's disease. And of course, there are the urologic manifestations of this that we just heard all about, erectile dysfunction, etc., and the counterpart in women. But there are many, many other challenges that people with chronic diseases and Parkinson's specifically have to navigate when they are navigating a sexual relationship with their partner. And that those include mental health challenges, depression, and apathy. Those include motor dysfunction, inability or a decreased use and dexterity in the hands, a tremor that may interfere. And then there's another layer on top of that, which is the fact that in the past, this couple may have interacted with each other as partners, but now there's another level involved in the chronic disease relationship where the person with Parkinson's may feel like they're being taken care of by their partner instead of having a more equal footing, and that can get in the way. So, and many, many more. So there are many, many challenges that a couple can experience that really go beyond just the urologic dysfunction, which is super important and treatable on some level, as we heard, or on many levels, as we heard from Dr. Alukal. And so we decided to step in at this point and try to create a resource where couples can actually try to navigate this relationship in different ways, that it isn't necessarily only about sort of maintaining the erection, but it's about maintaining the sensuality and the intimacy between the couple. And we, together with Havas Health, created a kit of items that a couple might find helpful to spark a conversation or kindle a relationship that, or part of a relationship that they didn't even know existed. And so this kit has 6 elements to it. And those elements are a bath bomb, a feather, a blindfold, touchstones, massage oil, and the last one is a scented candle. So those are the 6 elements that are contained in this kit. And along with this kit comes with a book, is an instruction manual, pretty much about how to use the kit and how to use these elements to spark new ways to interact. So here is an illustration of the book, and the book is divided into different chapters. We have the first chapter, which talks about the importance of making time to engage in these activities. The second is creating an environment that may stimulate the senses. The third is exploring physical activities that are forgiving, that may not have been part of the relationship before. Fourth, reducing inhibitions. And in these chapters, the different parts of the kit can be put to use. So for example, in the environment chapter, the discussion of how a scented candle can be used. In the physically forgiving activities, the discussion of how the feather and how the touchstones can be used. In the reducing inhibition section, a discussion of how the blindfold can be used. What's important to know is that as this book was developed, the illustrator was very conscious to create imagery that did not predispose anything about the people who may be involved in this relationship. So the illustrations relate to people of all ages, of all genders, of all sexual orientations, of all races. And so it isn't just, 2 pretty people, but it really tries to encompass what a real live person with a real live body that maybe not cooperating at all times would potentially look like. And so here's a picture of the kit. On the left is the kit with the book in place, and on the right, the kit with the book lifted off. And you can see the different sections where the different elements are located. The book itself has little tabs so that you can move the pages more easily if you have some manual dexterity problems. And the small items are attached to a little tab so they can be lifted out of the box easily. We got help from Sheila Silver, who is a sexologist who has particular expertise in Parkinson's disease. And she helped us write the introduction and really frame the book, reviewed all the content and framed the book so that it really was meaningful and had an impact on people with Parkinson's. And I'll just flip through the book itself. We also want to mention that the elements in the kit and the kit itself were reviewed by people with Parkinson's disease. There was input from the community themselves, which is, of course, extremely important when it comes to any resource for people with Parkinson's, and especially this one. The middle couple, Allison and Stephen, were very open. They were happy to have their photos shared on this type of presentation. They are a couple who both have Parkinson's disease. They met both as after their diagnoses and joined together and are now sharing this journey together. and they were able to review the content for us and give us a lot of excellent feedback. And then there were other people with Parkinson's who wanted to remain anonymous, who were part of this process as well. And so we want to thank them for their participation. And finally, probably the most important part to tell you is, how do you get a kit? So it's actually quite easy. You go to our website, apdaparkinson.org/ParkinSex, and you can do 3 things on this website. You can watch an animated version of the book. So it's read aloud, and the illustrations are animated, and you can watch the book in that way. In the second tab, you can download the book and get a PDF form of the book. And then you can actually request the kit here as well. And so if anyone would like their own, they can go to our website and request one, and it is a free resource for the community. On that note, I'm going to stop sharing, and I am going to ask Gloria to take over and to convey her messages to you as well.
Good afternoon, everyone. I'm really happy to be here today to discuss the couple relationship and some of the sexuality challenges they face due to Parkinson's disease. And I'm really happy to be following Dr. Gilbert, because a lot of what she talked about, I'm actually going to be expanding on. There might be even some repetition, but there'll be certainly an expansion on some of the things she talked about and some of the techniques that are used in the ParkinSex kit. We all know that Parkinson's has a profound effect on the individual with Parkinson's and also on the care partner. It's really important for the medical and the clinical community to recognize and understand the physical, psychological, social, and sexual effects of Parkinson's on the relationship, and for professionals to be willing to raise the issue and address it directly with empathy, compassion, and with direction. I want to talk today about a few significant issues that are related to Parkinson's, and then we'll close with some real specifics about what professionals should be thinking about when treating an individual with Parkinson's and their partner, and with some interventions. I think the first thing we need to talk about for a moment is, what is the impact of this disease on the couple, and how does it affect their sexual relationship? So first, the individual who has Parkinson's. There are various motor and non-motor symptoms. We all know about those. And what they do, some of the impact on some individuals, and I'm going to use the word some because it's not everyone, is that some will feel more self-conscious, less attractive, more passive physically, because they do not have the motor capabilities and the mobility. They're less motivated and interested in general. They're dealing with some apathy. They're coping potentially with depression, anxiety, and some impaired self-esteem. Now, the result of that, and we've seen this in our clients' patients, some withdrawal, social withdrawal, some isolation, potentially reduced communication, whether it's because they're physically having difficulty communicating or just emotionally communicating, greater apathy, and a lack of expression. So some of them are dealing with that mask. And so their ability to show their feelings and emotions toward their partner has been impaired. They do miss, and clients have said this to me directly, they miss the sexual connection and the intimacy, but there is a great fear of performance failure. And they're also afraid they're going to be rejected by their partner. And they're afraid that there's going to be physical pain associated with sexual intercourse. So the result of that is less sexual interaction and less initiation of sex. Now, their partner is dealing with something else completely. They have sort of contradictory roles. On the one hand, they naturally want to have sex. They have feelings, they have desires, they want to feel needed, they want to feel attractive. Those are coupled with feeling overwhelmed with responsibilities, sometimes worried about their future, feeling fatigued, experiencing anticipatory grief over the progressive nature of the disease, mourning some losses that they're dealing with, the changes in their relationship and in their partner, and they're feeling somewhat lonely and resentful. They too miss the intimacy and connection, but they're either too exhausted or resentful to participate, or they feel too guilty to ask for it, as if asking for sex or initiating sex is less important than what their partner is experiencing with all their other symptoms. So both experience this buildup of unexpressed emotions and frustrations. So what do? What's the remedy? Well, we know that there are going to be some sexual remedies, but the biggest remedy across the board is communication. They need to start to talk to one another. Silence, unexpressed feelings lead to greater isolation and loneliness and more resentment. And we all know this in any relationship. When you don't talk about things, those things build up. Starting to encourage open verbalization of thoughts and wishes with the couple is critical. They need to reconnect on a deeper level, which creates intimacy. And you need to start with a non-sexual connection. You can't start with a sexual one when the emotional non-sexual connection has been reduced. The couple needs to talk about the stress. They need to talk about the changing roles. They need to increase mutual enjoyment and pleasure. They need to get reconnected again, which will increase self-esteem and self-perception. Some more open displays of tenderness will increase emotional closeness over time. They need to talk about those things, but they also need to feel safe enough to express their frustrations toward one another, because that is part of the deal. Without expressing those frustrations, they can't also express the closeness. Prioritizing intimacy as a couple is critical and should be viewed as such by everyone, the professionals, the clinical community, and the couple themselves. So what do you do now? What's next? So the next thing is to begin to try non-sexual expressions of intimacy. Those have to be cultivated. Intimate, non-sexual touch. That in itself produces chemicals which lead to improved self-esteem, vitality, even reduced pain. So practicing more hugging, more touching, that is really important without the sexual component. And we're not saying that the sexual component isn't important, but you can't start there. The other piece that's very important is, and I think Rebecca alluded to this, is they both need to redefine themselves as a couple again, and not as just a couple with Parkinson's disease. Unfortunately, often, once people receive this diagnosis, this absorbs the individual and absorbs the relationship. And I can tell you, constantly thinking about Parkinson's disease, constantly talking about the disease does not bring romance to the relationship. They need to find and cultivate interests that they had before and new interests. Each individual in the couple needs to be able to cultivate their interests. They need to refuel. They need to see their friends. Then they need to come together and function as a couple again, and not just as a caregiver and a care recipient. Rebecca alluded to the power in the relationship. There needs to be equality again. There needs to be a give and take again. And that is not going to happen if they are just defined as individuals struggling with Parkinson's disease. So now, what is the role of the professional here? So individuals with Parkinson's and their partners are often too embarrassed to talk about their sexual needs. They dismiss them as less important than all the other symptoms that they're experiencing. Some don't even connect the fact that their sexual dysfunction or intimacy issues are even connected to their Parkinson's. Often the care partners are also too embarrassed to verbalize their needs, or they don't want to hurt the feelings of their partner with Parkinson's, and they don't want to complain or be critical. This creates this wall of silence that we're talking about. Healthcare professionals need to be aware of the fact that most individuals with Parkinson's want the healthcare professional to initiate the conversation. It is very important to have this patient-centered approach where discussing their various quality of life areas are just as important as discussing all their other symptoms. Recognizing that an individual's sexual health and need for intimacy is as important, and if they work on that area, there will be less isolation increased self-esteem, greater connection to their care partner, more energy and vitality, and a greater ability to adjust to all the life changes that are occurring in their life. And if the medical professional is struggling with having this conversation, they do need to refer them to either couples therapy, individual therapy, a sex therapist. There are so many other professionals out there who are very comfortable with the conversation and would give the individuals the space and the safety to openly have that communication with their partner, which is so necessary. And I just wanted to end with some tips that either with a professional or even with each other, these could be some things that a couple can do to improve communication and improve some intimacy. First of all, they do need to sit together and have an open sexual conversation. They need to plan the setting of that sexual activity, the time, the location. They need to plan sex for when movement symptoms are lessened, and they also need to plan positions in advance where there may be less movement between positions, so they are just more comfortable and it is less painful. They might need to adapt new sexual roles. The person who may have done the initiating might need to hand that over to the other person to do the initiating. They need to find some solutions for physical limitations. Rebecca mentioned the massage oil, using lubricants, using satin sheets to ease movement and to increase romance, to engage in intercourse, but what is also something called outer course, which is really general, non-sexual ways of communicating and touching. And they do need to work with medical staff to reduce the effects of medication on sexual function and to ask for help. So I just want to conclude by saying that I'm really so happy that we are finally opening up this conversation. I think it's long overdue, and we all as professionals here have to recognize that while we may not be talking about it, our clients and patients are not only talking about it, they're thinking about it, and they're worried about it. And we want to give them a safe space to be able to share their feelings and look for some solutions. Thank you.
Thank you so much, Dr. Gilbert and Gloria. That was fantastic. We are going to move on to the last section of our course, where we will hear from people with Parkinson's and care partners about this important topic, and they will take your questions. Excuse me. I do encourage you, if you have questions for Dr. Gilbert or for Gloria, just you can put them in the chat. We will make time after our discussion with the participants here in just a minute to answer all of your questions. In addition, I'm going to stop the Zoom recording at this time, and Gloria will moderate the conversation. So Gloria, I hand the mic over to you. Thank you.